Live.
Yes, sir, we are live now. Thank you. Over to you, sir.
Hi, good evening, everyone. Today we are in our second lecture. We all know biostatistics. We have been taught in our undergraduate days, and now AI is coming in a big way, and we can't live without AI. To take us through this journey of gentle bridge between biostatistics and AI, we have an eminent speaker with us, Dr. Kishore Dara, PhD, and winner of Thomas Alva Edison Award in 2015 for his innovations with 35 plus patents. To take us through this journey, we have Mr. Neil Ghosh, who is the moderator, who will be going through all the questions, and he will start with some of those housekeeping elements to start with, and then we will go with Dr. Kishore Dara for his presentation. Over to you, Neil.
Good afternoon, everyone. Thank you for joining, and thanks NBMS for the opportunity. Today, we have the second lecture. I'm Neil Ghosh, and I'm today's moderator. Let's go through some of the housekeeping for the next 1 hour of lecture. Please log in through only the registered email in the portal that you have signed in with. The feedback link would be sent only to that email with the subject, your personal attendance and feedback link. This will mark your attendance automatically. Do not use anybody else's link and do not share your link to anybody else because that would not really mark their attendance. You don't need to put anything in the YouTube chat to mark attendance because it creates a lot of noise and very hard to pick up the questions. So please ask your legit questions related to the topic in your YouTube chat so that it can be picked up by the moderator. Without further ado, let me quickly bring in today's speaker, Dr. Kishore. He is a PhD in computer science from Iowa State University. He is the winner of the iconic Thomas Alva Edison Patent Award in 2015. Currently, he's acting as Chief Innovation Officer in BurnTech. He has a long list of accomplishments everyone must have seen in the teaser already. So, Dr. Kishore, please take it over when you're ready. Thank you.
Thank you, Neil and Dr. Suresh, for the kind words. So let me share my screen. Okay. I hope the screen is visible. Yeah, good. So I'm going to start with the second lecture in the series of this wonderful initiative by NBMS on AI in healthcare for medical professionals, right? So to cover biostatistics and AI, even as a gentle bridge, in 35-40 minutes is a big task. Usually this is a semester long, a much larger discussion. But let me try to see and achieve the objective here in a short span, and then let's see. So the agenda that I'm going to talk about today is first to start off with physician above the tools. That's the theme. And why I'm trying to lay out what the core objective of a physician, and then the rest of whatever is used is a tool. And then we're going to start about what we already know in terms of biostatistics and how it is used as a core foundational language for evidence in the clinical space, in the healthcare space, right? And then why transition? Why we already been using it? Why transition to AI? And then later I'm going to take a detour and then talk about AI is not a one thing. It's a different flavors, and each flavor has to be understood clearly. And then the evaluation, where its application has to be understood, because we do see them in all flavors across daily life, especially in a clinical setting as well. So finally, to some sort of cheat sheet on the terminology, because there's certain terminology biostatistics uses and certain terminology that AI uses, and I ended up with some takeaways for that from the lecture. So let me start with physician above the tools. So what's happening is, we are hearing a lot of, you don't need to read the text there. I'm just saying that we're hearing a lot from healthcare and big tech. When healthcare is saying, we're going to design the best perfect drug molecule, we're going to do proactive healthcare, we're going to do that, change the diagnostic workflows. On the big tech side, They're saying that AI is bringing the transformational technology. It's a huge business opportunity. It's going to empower doctors to better serve their patients. Amidst all these things, what we need to understand is the physician is a central role here. And like Hippocrates observed, it's important to know what sort of a person has a disease than to know what sort of a disease a person has. So if it really translate that, right? So it reminds us again that it's about the patient, not the disease. So, and if you're moving from evidence-based medicine to personalized medicine, it's always the patient, right? So the reason I'm bringing this up is because this is how the transformation from biostatistics to AI is going on. And as you can see that the central role here is this, and physician is the final clinical and moral arbiter here. So understanding these tools, understanding this transformation, where to apply becomes very, very crucial. Okay. So let's start looking at biostatistics as a foundation, which we already know, right? So we already know that, most of us use biostatistics as for causal evidence. Does this therapy, does this thing really improve my clinical outcomes? What is the effect size? How large is the benefit? What is the NNR? And how generalizability? How can I generalize this? Or this study, does it apply to my patients? So, and then the diagnosis as probability. So typically we do that, right? The clinical outcome would be like, given this test results for my patient, there's some personalization going on a Bayesian level. How likely is the disease in my patient? So finally, a big thing about biostatistics is the uncertainty in decision making. So how confident? What is the confidence interval? And using this, physicians have been using biostatistics to actually tell how effective and safe their decisions are and how confident are they about, and then that's usually be communicated to the patient as well in one form or the other, right? That has been happening. So another way to look at this is what the left hand side is the same. The right hand side is actually the statistical methods that are used here. For the two kinds of physicians, right? The one physician is using this, one physician is trying to develop these kind of studies. So these are some of the things for that kind of physicians as well. So for causal evidence, you do the RCTs, the causal inference methods, and the validation methods of the p-values, your confidence intervals, and similar things like that. So for a diagnosis probability, like I said, it's Bayesian. Use the Bayesian probabilities, likelihood ratios, and a lot of these things are the right hand side is exactly the statistical rigor for the clinical decisions that have been can be based on. Okay, so now why bother about the transition? I'm already using the statistics for over 100 years. Why bother this transition? So this is a very text-rich slide. That's why I tried to highlight the with colors so that you can focus on this. So typically in biostatistics, what happens is the average treatment effect is what you're studying. Okay, and then and any subgroup analysis is limited to whatever is being studied, right? And typically when you do a biostatistics modeling, you do with few variables, and you work on very clean, structured, labeled data. Okay, so that's fine, that's wonderful. But with all the new kinds of imaging coming in, with all the kind of signals coming in, the EHR records in text form and mixed forms, multi-dimensionality coming in, there's huge high dimensional non-linear data that is coming in. So how do you process that? How do you actually use that in this kind of modeling, in kind of statistical? Because it doesn't, is not enough there. The second thing is, I don't want an average treatment effect. I want to understand what the risk analysis at a personal level of a patient. Does it work on average, but will it work for my specific patient is what the probability is, what I want to understand, right? And also if I want to say who benefits, who is harmed, and what happens for, is there any counterfactuals or any treatment effects that can happen. Finally, I also want to have a streaming things that as the data comes in, some of the things may change. For statistical models, what happens is you need to go back and redo things, or you need to, it's on a static estimate. But I want a dynamic estimate, dynamic predictions. So that's why AI enables physicians to detect patterns and make personalized predictions. And these predictions are coming not just from statistical created clinical trial data or things like that, but it's coming from high dimensional. It can come from high dimensional images, signaling, all kinds of data, structured and unstructured data. And then, okay, so now with that, I'm going to move and say, what is AI? Okay, so now we said AI is going to do this wonderful things of understanding patterns in high dimensional data and all the stuff. So let's decipher what AI is, because there's typically we just generally using AI does this, AI does that. And in general, I'm going to use digital pathology as an example to show that there are different flavors of AI, and each has to be treated differently. So you cannot bucket them when you're let's say you're reviewing a study, or you're trying to adopt a model, or you're trying to change your workflow. You need to understand that each different components of AI and what kind of validation mechanisms, what kind of things that you should be using. So for example, you're taking these slides, and then and then you're trying to detect tumor subtyping grading. And like I see, the data is very rich, right? So, and the AI that you're using is image analysis here. Okay. So if you take it and then go further step, and then you're trying to predict the treatment response, you're trying to predict what is a mutation, whether the mutation can happen or not. Then you're using image analysis model plus another model that uses predictive power. Those are two completely different ones. Can be completely different ones, right? So and if you're still further going into a little more deeper, and then say, I want to do an inference on gene alterations, I want to do morphological features, or I want to unearth biomarkers. Okay, so you are using another model like image analysis, predictive power, spatial and temporal, patterns with respect to biological interaction. So AI comes in multiple flavors, and each one, whether you're doing image analysis, you're doing using some sort of predictive power here, or you're doing some sort of pattern mining here, comes completely with different perspectives. So what I'm going to do in the next several slides is decipher this and get to the basics of what can we look at it, and then understand. So the biggest call out on this slide is AI isn't monolithic. So we can say AI model, but internally, when you're evaluating, you need to understand what kind of model is it. Okay, and I'm going to walk you through with this kind of model, like what originally with statistical modeling, then with machine learning, then deep learning, and GenAI, with 4 different dimensions. For each one of those, I'm going to discuss what is the learning objective of this. So that means what is it trying to do, and correspondingly, what is the clinical value of it. Okay, and the bottom layers tells you what it's built on, and how do you validate or trust it, or if you're using it, the trusting, and you need to understand what is a validation method, the appropriate. If you're building these models, you need to understand what kind of models, what kind of things are expected. So the next several slides, I'm going to walk each one of them and then compare again the adjacent ones as well. So so let's start with statistical methods. So it's like we discussed this before. It's a formalization of inference. You do hypothesis testing. You reject the null hypothesis. You know that, right? The p-values are much lower, and then you do. This one gives us the estimation of effects, uncertainty, which we have discussed earlier. The clinical value is again the same. I'm just for completeness I put in there. So is the treatment improve? How precise an estimate, or how wide are the confidence intervals? Is it too wide? Then I cannot say anything. If they're too narrow, that's good for me. In some sense of there's higher confidence. What kind of data that it's built in? It's built on, like I said earlier, small, clean, structured label data. Why small? Because these are statistical methods. You pick the variables, you do the analysis, and it has to be, it cannot blow up. The complexity cannot blow up in this, and it cannot handle that. So these are but it gives the mathematical rigor. Okay, and then the validation obviously is what we know. We have p-values, and effect size and other things. From a clinical perspective, they could be, bias control. What is the, you can understand what the causal interpretability of the estimates, and so that's where the trust comes in. So if you understand, this makes sense because there's a causal interpretability, and that kind of corresponds to the biological aspects of things, then you're kind of have a solid trust in that. So moving on, if you go to machine learning, I'm going to divide the AI from machine learning, deep learning, and finally talk about GenAI and a bit about chatbots, so that we get the entire gamut of things and then understand in the larger context, because we're using all of them in one way or the other. So what machine learning, the classical machine learning does is, in some sense, it's a formalization of statistical learning. So some of there's a huge philosophical argument between these two things, which is machine learning and which is statistical extension of statistical methods. I'm not going to go there. It's not relevant for this discussion. I'm going to say that it's a formalization of statistical learning, plus there's an algorithmic optimization. So there's several algorithms come into play. The typical tasks is pattern recognition, classification, and prediction. See how we moved from inferencing to prediction and recognition. So the kind of problems from a clinical perspective machine learning is going to answer is not inferencing, not causation. It says I can predict the risk of deterioration. I can predict sepsis. I can predict if somebody has as in the next 8 hours, do they need some sort of ICU transfer, readmitted. So that's a kind of early warning systems, the length of stay predictions, that are very relevant, and that can come into play. So it is not, you may not get the causation for that. Excuse me. Not get the causation for that, but this prediction is quite valuable in the workflows. What is it built on? It's typically built on large scale EHR data, electronic health record data, labs, vitals, medications, and some personal information from the patient, in the EHR data, and time series, all kinds of data. Again, like statistics, a lot of machine learning, the feature engineering, that means the how do you extract, or what are the variables, predictive variables are engineered, and the risk models are built on that, or the prediction models are built on that. So how do they validate? They kind of split into seen data and unseen data, which are the train and test kind of a thing. They do some sort of a technique called cross validation, and they understand, other methods. The thing that from a trusting point of view, what we need to look at for these kinds of things is, what is the generalization of the performance? Is it an overfitting? That means, am I seeing too many exceptions here? And finally, like any AI thing, you need to understand what is the clinical utility of the predictions. If it is machine learning or deep learning or anything, what is the finally? I mean, yeah, the question is good, the objective is good, the clinical value may be okay, but is the prediction, is the validation that they've done makes me trust the clinical value of it. Okay. So going to deep learning, this is where things get a little interesting. So it's what happens is you're in. I'll try to explain the first part of the learning objective here, which becomes very interesting later on as well. The thing that it's doing is it's not trying to learn an image, or when it's trying to learn an image or a voice or text or anything, it's trying to learn a higher order representation of that. So what with that, and that's what neural networks and end-to-end optimization. What does that mean? That means you can extract your high dimensional feature, and complex pattern matching. So you're not looking at standard data distributions and things like that. You can throw millions of images at it, and then say, okay, now you convert this image into a different space, and try to understand the relations between that. If there's a context, if there's a nose next to an eye, there's a ear next to an eye, it's a face kind of a thing, right? It's understanding representations. Think of it that way. And then why is it useful? I mean, it can do many things now. Okay, it can do radiology, even image reading, pathology. You most of you are familiar with this kind of models that are coming into play, right? But fundamentally, like I said, the statistics, again, going back to statistical methods, which is giving you the inference, which is giving you mathematical foundation for causality and other things. When machine learning is giving the prediction, the deep learning is adding from prediction another thing called perception. So it's perceiving the representation of vision, speech, and language, so that it can do, these two are similar, these two are different, and I'm looking for this kind of a thing in a radiology image. Did I find that? And then predict how close it is with some some probability on that. So that's a jump here. That's what is happening, and that is what is coming into play. So of course we all term everything as AI, but I'm just deciphering so that you understand the next time when you see a model, a radiology image model, you're looking at a deep learning model, and then the validation that you need to check with them is, it runs on huge unstructured images. Okay, and then it's going to, there's no manual intervention. So somebody labels it, but they don't tell exactly what features should be selected. They'll tell this is good, this is bad, this is good, this is bad, or this is what I'm looking for. And it has an ability to go and find the pattern of all the things that you're looking as label 1 and label 2 as no, and understand that. So again, coming back to here on the validation and trust, again, your sensitivity, specificity, and all those things come in because you're actually directly using it for some sort of image reading and other things, right? So suddenly in the trust thing, you need to look at, is there a consistency across the images that are coming in, across different scanners, different sites, different things, because now you're talking about high dimensional unstructured data. So images or signals are coming in. Is there a consistency? Because a model built on certain kinds of images may not work on other kind of images. Again, clearly it doesn't work on it may not work on a different set of population. So these are the things that you should be in the lookout when you use these kinds of models. So is there standardized images that are coming in? Most probably they are, because but there are quite a few instances that they may not. So we need to understand that as well. So the data foundation is this, and the validation exactly, because the unstructured images are coming from different places. You need to understand that. So that's what deep learning is adding perception to your prediction systems and other things, right? So let's move on. Oops. Okay, to generative AI. This gets a little, I'm trying to wave my hands here with respect to deep learning and GenAI, but to just follow the narration, I'm just doing that. So remember I said in deep learning, we are understanding, some sort of representations, and GenAI is actually learning that representation. I'll come back to that. Here, the primary goal learning objective of GenAI is to content synthesis. That means it's trying to generate something, scenario generation, or it's trying to simulate something. How does it do? Just park the thought. I have a different slide on that because this needs to be dealt slightly differently. So I'll come back to that. What's the clinical value? Today, the clinical value, I mean, it's very hard to, for most of these, it's very hard to say what the clinical examples going forward. But today, some of the examples are clinical note drafting, discharge summaries, or differential diagnosis. I'll talk about that a little later as well. And you want to do some sort of simulation on care path, pathway simulation, you can do that. Again, the data that the data foundation that's are basically clinical notes, guidelines, textbooks, and other things, right? So so the validation and the trust, again is on the suddenly. Okay. So the validation and the trust on the GenAI models is slightly different because you're generating content. When you're generating content, typically a human expert review or something has to understand whether the generated one is actually factually consistent or is there any hallucination that is happening. So in terms of a trust model, we need to understand how the prompt, how prompt stability is there. You different things. Is it giving the similar things, or it's giving completely different answers? It's safety across clinical contexts and populations. So going back, so this is, I know I walked through the whole thing. So what I'm going to do now is I'm going to put each of these next to each other and then recap some of the common important things. Okay, so that let's look at statistical methods, and I said they're very close, and machine learning. The first objective the question and the objective is in biostatistics, inference is the main thing. Is the treatment effect or association real and clinically meaningful? Is what you are trying to learn, right? So and in the machine learning prediction, I'm talking about non-DL. That means non-deep learning. Does the model predict outcomes? Does the model, can this prediction support my clinical decision making? Okay, leave the model and method because we already talked. I added here for consistency so that as a notes it reads well. Okay, and the physician side, on the clinical use, I can use it if I can replicate it in similar cohorts, and if the precision and applicability to my patients are proven, and then can I trust this evidence at my bedside, right? On the machine learning, you need some sort of external validation on a different data set. And then how can you transport this or do any calibration as the data set changes or things like that? How do you do any calibration? Because there's a shift that happens. The shift is because remember, machine learning is predicting as the new data is coming in. We're not building a new model. This is learning from that model. So it's operating on the model. So does the data shift happens or the model shift happens? Does the result still valid? So we need to understand that. So with that, we need to say that this tool is really useful in my clinical workflow. Okay. So the machine learning and a closer look on machine learning, deep learning, like I said, the model again is predicting on the machine learning side. So in the deep learning side, now the question is different. Is the model perceiving it right and interpreting right? Okay, it can have prediction also. It predicts a representation, and then say based on this, I'm going to it perceives a representation, and then based on that, it can predict a diagnosis. That can also happen. So it's adding that feature. So from a clinical, from a physical physician and a clinical usage, the accuracy, a human expert, what are the edge cases? So we are sending it. Is it perceiving the right things in edge cases? What is the consistency across devices, like we talked about? And what am I missing? Does it matter if I miss something? What I see and not miss, and which ones are more important for me? The missing ones are these are some of the things that you should be looking at. Now, the deep learning and GenAI, slightly different, which is, I take a different tack here because they're kind of related. So remember what I said about deep learning. Deep learning is learning the representation. That means some sort of, if you give an image, there's some representation in the image, it's trying to learn the representation patterns in the image. Okay, and that's how it gets its perception, right? So that representation can be a vision representation or vision or speech or language, or any biostructures that you give, any domain specific representations that you build as a graph or any other kind of data, or it can be completely, to be complete, it can be any other thing like material science, how metals behave, how their chemistry works, all kinds of things. That's how the space is. Now, what GenAI does is it takes the deep learning representations which capture the structure. That means what is the pattern, what is the similarity, what is the context. For example, since I've been giving image examples, I will give a text example, right? If somebody uses the word apple, so it needs to understand the context of the text that it's used. If it is used in the context of eating, it's a fruit. If it's used in the context of of technology, it's probably a company, right? So it needs to not only understand pattern and similarity, and need to bring context together. So what GenAI does is it uses these things to produce whatever being asked as an output. So it's generating, there's a prompt or something coming in asking for something to be generated. So it uses what it's seen before and does it. It's not that simple. There's a layer that happens. There's a reinforcement, or there's a human in the loop, and kind of feedback happens. So they look at make this whole representation similarity into a reasoning model because of how things happen. So I know this is the only reason I tell this is because we're using ChatGPT and other things. So where we can test it and where we can use it, where we cannot use it, what is the limits of it, is where I want to go a little bit, or at least quickly highlight that. That's why I'm going here. So basically, what is happening? Your deep learning is giving you representations which capture structure, pattern, and context. GenAI is using them in one way by training and some sort of and building a reasoning model so that it can generate what it is asked in a very and it appears like it is reasoning with us in any domain. But you have to remember that it is not trained. These representations are only trained on vision, speech, or text, unless they're trained on bio. So foundation models like ChatGPT primarily learns and operates on text and vision. So it has seen something before like this. Yes, there may be some correlation, but it's not a bio model. It's not a medical, clinical model unless somebody builds it. like a specific models like AlphaFold, ESM, or Malbert, which are actually get these bottom two things, the biostructures, other structures kind of a thing. So they're learning representations and patterns from there, so that captures some of the domain things to bring in. So if that's not there, or ChatGPT and these things are primarily generating text, and if you're using advanced models, probably vision and speech, based on what they have seen before. It is not a medical model. It's not in that sense. Okay. With that, so it is reasoning about healthcare through language, while specialized model learn differently. That is why we need to be very careful on the factual correctness, hallucination, and the safety of recommendations and other things. I'm going to again talk a little more on that. Okay, and I'm going to talk about a little more on that, just I want to close out on on GenAI assistants, right? So ChatGPT and similar models are cognitive assistants, not a clinical authority, right? So they can help in structuring differentials. This is extremely important, actually. Sometimes, if you're seeing a lot of patients and you may miss out something, asking a ChatGPT for a differential diagnosis and see if there is any, explore possibilities, or if you're missing anything, maybe, right? So, and obviously, automation of summarizing evidence or drafting notes, it would be quite useful with some guidance, but it will never replace. Going back to the first slide, right? Never replace understanding a patient, understanding what clinical examination, diagnostic reasoning, and and other things. So in essence, these are helpful for ideas, so they can guide, but it's very dangerous if you trust it, and invaluable if it is critically supervised. That's today. Going forward, there could be specialized models that have been verified, but once somebody says that it's verified and you're reading the literature, you need to go back to some other things that we discussed and what they verified, what kind of data sets, what is the data foundation, what is the thing they're answering, and what kind of what kind of validation and trust that they're bringing in. Okay, and a few common clarifications that before we kind of go into typically association, prediction, and causation. I mean, these are basic, but I just so that we understand when we're doing things. Association obviously is variables moving together. And I gave some examples here as well. A biomarker may correlate with disease, but a model may predict risk, but only a causal evidence. The causal evidence is what gives tells you what treatment will actually. So that is the reason why still today, for a lot of studies in this area, biostatistics is needed. Even though you use AI, different flavors of AI to bring in features, to bring in predictions, finally there is a layer of biostatistics that will understand how it works on a population, and that's what a very standard method so far in the approval of models as well, from federal agencies or government agencies, right? So bias variance trade-off is a model. Is a model underfitting or overfitting? That means it's doing well, but it's doing well only for a small set of people, small set of subset. Or is it overfitting? That means it is too unstable. It's bringing too much noise, but making sure whatever I gave the data, it's trying to get the right answers for that data, and which is unreliable in some sense, right? So often simpler models are safer. The reason I say is because it's easy to explain. Complex models are harder to explain. And a lot of healthcare or a lot of diagnosis of physicians need to explain some of the decisions as well with patients, to patients. So that's why some sort of, when things flow when things are part of a workflow, maybe that'll be easier. But oftentimes, we do use complex models for some of the perception and other things that we bring into picture, right? So more data is typically not better model when you're evaluating a paper or when you're evaluating a research work or a model. Typically, you need to understand what kind of more data is, Is it like, evenly distributed, independently distributed, and there's no bias on the data and other things as well. So, and then the final sheet is this one. Actually, when you're evaluating some other things, the biostatistics uses it in terms like confidence interval, support, effect size, lift, or sensitivity, specificity kind of things, right? The AML side of things, though, remember the meaning the meaning of confidence interval in biostatistics is uncertainty of estimate. The meaning of prediction interval under uncertainty in AML is uncertainty of prediction. So you have to understand that the learning objective of both are different. So that's why both are needed in the flow, right, or in the models, right? So this is just a readout kind of a thing. So a lot of external validity and basically some of the things that come in. You need to just a cheat sheet so that everything is in one place for terminology. So finally, I want to go and say the key takeaways are there's a need for transition. Biostatistics tell you what is true, right? Evidence, causality, uncertainty. And as a physician, it's much easier to explain that in some sense, right? But AI gives you perception, prediction, and high dimensionality, which is actually needed because the data in the modern healthcare system is high dimensional, both from a patient perspective and from a care perspective as well, right? So and this can result in, if you bring those models that will improve the efficiency, that will improve diagnosis, that will improve all areas. So that's why the physician needs to be statistically literate in terms of to judge the evidence, judge a model, a statistical model, which most physicians are aware, I think. But the new AI aware is to interpret prediction. And here is where I'm in this talk. I hope I'm going to say that in the next slide, that AI is not one thing. So when you're interpreting, you need to interpret it on what kind of model that is using, and based on that. Finally, the clinical expert has to decide and take responsibility. So the second thing, like I hope I conveyed, is AI isn't monolithic. You need to understand the nature of the AI model, identify the clinical relevance to what the model is. That, for example, if it is processing 1 million images, it's giving you automation. So and the trust of the model is different than another model that is predicting, based on a large high dimensional data. So it all depends on whether you're using classical machine learning, deep learning, or GenAI, or even on top of that chatbots kind of a thing. So you have to understand, use the appropriate validation mechanisms, or you have to understand the appropriate validation mechanisms to start using that in the workflows. So finally, as we started, physician above the tools. Modern medicine is not an evidence by algorithms. So it is, an application. It's an application of rigorous evidence, awareness of the model and the data. So and it has to be guided by physicians' reasoning. So in short, it can inform, augment, and accelerate. That's where the automation comes in. That's where the acceleration is coming and the augmentation is coming. But AI cannot replace clinical judgment and accountability and the patient bedside reasoning. So with these three key takeaways, hopefully I made a case for these three, and how physicians have to look at AI, not in one flavor, but in multiple flavors, and where to use biostatistics, where to use different flavors of AI, how to evaluate them. In the coming lectures, as you look at data sets, as you look at other things, and as you progress in this course, I hope you use this kind of perspective in looking at when somebody is introducing, let's say they're talking about radiology, then only one part of deep learning or machine learning is used there. So we need to understand what to be evaluated here. So hopefully this lecture gives you that transition, what is happening, and what is the parameters that you should be looking at, even though everything is called as an AI. Okay, thank you for it.
Thank you very much, Kishore. Before I just hand it over to Neil, I know we doctors work on very, very basic things. Kishoreji, I mean, it was a great lecture, great to learn, but at the same time, I was following some of this chat box. let me understand from a doctor's perspective. Okay. And then you can stop scaring the screen so that, we can. Yeah. So, first, if I just paraphrase biostatistics as a news, that means something already happened. I'm just reading it. And A as astrology. Is my understanding correct? I'm just trying to become a 5th class student or 10th class student at a very basic level. If I just try to give this analogy.
No. You should see that in multiple perspectives, Dr. Suresh.
Okay.
Biostatistics is a foundation where whatever happened, you're using understanding the distributions of whatever happening and then make conclusions on the distributions in some sense of the population distribution. So you're kind of computing on an average what happens, on a distribution level what happens. Okay, and the distributions can be subgroups. That means distribution of this kind of population, distribution of this kind of population, or above age group of this, that kind of a thing. That can happen. That's the best personalization that can happen there. But AI is bringing multiple dimensions. One dimension it's bringing is there are these this multi-dimensional data, images, voice, and text, which cannot be put in distributions. So you cannot study those in distributions.
If I understand, sorry to interrupt, if I understand, statistics will look into the numbers, whereas AI can look into the numbers, speech, as well as images, which the classical biostatistics cannot do. Is my understanding correct, sir?
In some sense, that's one part. The second part is the learning objective itself is different. AI is trying, statistics is trying to give the mathematical foundation of inferencing. A causes B, the causation. Okay. Right. AI would say, I'm predicting what happens because I've seen the data of 1 million patients in this scenario. And when I get a new patient, I'm using that knowledge to predict what may happen to this patient.
Got it.
Trying to put this patient in a distribution and then say, with some, I'm not doing that. I'm just saying that for this patient, I'm learning a model and then, so it's doing high dimensional. It's also doing predict the itself is different. That's why it's very important to understand that because you're evaluating in that way.
Great. So if I just put it, it is like learning the MBBS is like, I can say it's like a learning and inferring is what what we call is a biostatistics similarity. As we practice, we learn from the patients and try to predict what will happen to the patient. Like this patient will do well, this may not do well. It's such an experiential thing is AI. I mean, if I just want to put it in
the prediction can be at a patient level, prediction can be an images level or anything. In this image, this patient may have this, this disease, or this patient may see a progression of this, things like that. Any prediction, yes, absolutely. It's a completely different perspective.
So how to do the prompts and other things? There are a lot of other questions, but if I just have to put, the biostatistics is there to infer based upon the data, and AI is there to help, including the voice, images, text. Sometimes it can think. You cannot trust it for its accuracy, but it is good in giving ideas and helping you in summarizing and then just doing those things. Is my understanding correct after the class?
Right. So let me walk you through that again. So the part that you said about biostatistics is right. So it's doing the inferencing. So it gives the causality, and then the what can happen on an average to a patient. When a patient comes in, you get whatever you get, and then you put him or her in the place, and then say, okay, on an average, this happens. On the AI side, what happens is you put them in a predictive model. What can happen to them? So the questions are different. Okay. So the predict what did you. The third one, when you put in a GenAI, so you have to remember what is happening is which GenAI are you putting them in? Which model? A model that is trained on text, a model that is trained on vision or text, which hasn't seen medical things. It's not trained on special medical things. So it has seen the literature of medical, all the journals of medical. So that is why it's doing that. But remember, its primary goal is to predict the next word, not the next value for the outcome. So right. So the next word, how does it predict the next word? It's predicting next word because it's seen a very similar words before as a prediction of next words in the medical literature. That's why it's predicting. So it's mostly okay because there is a layer on top of it, but it's always not trusted until there is a critical, you have to evaluate that as well. Yeah. Did that answer your question?
Absolutely, yes. I hand it over to Neil. I think you have more than 1,900 questions popped up so far. So just summarize and then just put them into top 3 buckets, and then we'll just continue the discussion.
Thank you, Dr. Suresh. Yes, there has been overwhelming amount of questions. So I'll probably put some of them across Dr. Kishore and put him on the spot to answer or give relevant pointers for checking it later. One of the first question that we got was, where do we get more information, more reference and more material after this class? Let's say somebody wants to start from zero, want to understand the basics after this class. Do you have any books or article or journal recommendation for them?
Yeah, we can try to provide, but it depends on two things, right? Like I was saying, there are two kinds of if I'm a physician, there are two kinds of roles. I mean, maybe there are more, but one is I'm adopting a model, so I need to understand what the model is because it's what modern medicine is. Okay, so that's one thing. The other thing is I'm actually helping build a model. I'm actually building a predictive model with somebody, right? So that the learning of these two is different. So you need to understand that. So for this part, NBMS is doing a wonderful job of doing that first part in these lectures, right? The second part, like what Dr. Suresh had mentioned in the introductory this thing, there could be very focused sessions going forward after this series is over. But to do it on yourself, we can provide some links, but depends on what level you want to go. But we can certainly suggest some links on, yeah.
Great.
That's it.
Yeah. Next question, Neil, please.
Thank you. So we talked about the statistical analysis, now transitioning to AI. Can't the statistical analysis itself be done by the AI? We continue to do that. Can the power of AI be used to do statistical analysis faster or in a better way?
From a computational perspective, yes. That means you know what you want to do, what kind of analysis that you want to do, right? So you want to build new kind of statistical methods, that's different. But that is where it's being automated. For example, I'm a physician. I did a study of some X number of patients. It's a very classical way of presenting, right? Some of the work, right? And then I found something, and then I do a statistical relevance of that using some p-values and other things. So that part typically earlier, what I hope no statisticians are here from what I'm going to say. Okay, so if that part is there earlier, what you should do, some of the papers that I co-authored with physicians is once we've done the work, even for the predictive models, right? Once we've done the work, we put that effect in population and then bring a biostatistician so that they verify, they kind of look at it in some sense, right? So that part, if you know exactly what that is, there are models sometimes can actually give you that kind of but you need to use appropriately. So you know how to use it and how to, well, again, remember, it's not about whether the GenAI chat or any of these assistants can give or not. It's your ability to understand the factual correctness of what it gives. That is very important. For that, you may need a statistician, or for if you know statistic enough, then you're fine. If not, you need a statistician to do that as well. If you're not building new statistical methods, yeah. Good. Is that?
Yep, that partially answers that. Thank you. So we are seeing some questions in the chat box, I think, regarding what is the best tool to use. And we have some questions very specifically focused on, can it be legalized to submit our data into the chat GPT? Is it correct or not? How far we are following the HIPAA? How safe is chat GPT not hijacking us? How it is not influencing our mind? This sort of questions I'm seeing more in the chat box. Can you just throw some light on that, Dr. Kishore?
On the privacy part, it's if you're using this at a personal level, there's no guarantee.
No
Okay,
guarantee.
no guarantee, right? So data is going out
That's
there.
a dangerous.
But some enterprises have an agreement with with a closed with a private deployments, and and you go by the agreement, and you I mean, knowing enterprises, if you trust that agreement, you're fine. Okay. So, but if you're using off the shelf ChatGPT, I mean, or any other models, we don't know. We don't know, and obviously they will be using. That's the whole point of enhancing them as well, right? And what kind of a thing. So that's typically not a good idea to send data, even images. Not when I say data, I don't mean text data. I don't mean patient this thing. I mean text, voice, anything. Any data is like multidimensional here. So that's so. And that's how I view Dr. Suresh. So you should not, unless it's going through an organization, that organization guarantees or put a layer of masking. There has to be some things happening there. Otherwise,
Don't share it directly. Got the message very clearly. Thank you for that. There are a lot of questions coming up. This is only a bridge class. When I say bridge, it just introduces the things, but you have a separate data class, which tells what is data, what is missing data, then what is true machine learning. We are not going to teach everything in one class. This itself is overwhelming for a few of those people. So we want to go a bit slow from the next class. We took your feedback very seriously. We just want to try to reduce the content further and then just do that. Neil, over to you for further questions.
Okay. Some of the questions were related to in the beginning of the slide when you said AI, the major power of the AI comes where it can handle the higher dimension of the data. So what are the higher dimension patient feature that it can deal with which biostatistics would fail to probably handle?
Yeah. The clear, right? One of the things is any visual, any images, anything, very simple, right? It cannot, biostatistics cannot understand, right? It has to have numbers in a structured format. That's where the statistics come into play. So that's where for the simplest answer would be that. And another answer would be even in that domain where you assume all the data of the patient or everything is in the same similar thing. Let's say there are several hundreds of variables, parameters that influence certain prediction. So that's when it's very hard to model that in statistics. So that's where also another other area comes in. But the major thing is this whole dimensionality thing that's coming in, and how it's actually looking at various because text is only one not even text is also it cannot understand, right? So numbers are only one aspect of data. Text, voice, images, all these are data. When you say data, that's where the multidimensional data is coming in. But again, the complexity blows up. Statistics is where we need ML and DL, machine learning and deep learning. Once the complexity is blowing up, because a lot of factors come into play when you're trying to make some predictions based on a lot of variables, not just a few of them. Yeah.
Just to take that from there, what is the difference between perception and prediction is one of the questions that is popping up very frequently in the chat box. In a medical language, let us assume X-ray or something, some medical example you can take and let us know.
So the perception, I'll talk about prediction first, right? So the prediction is you're looking at a high dimensional data or whatever data of a patient, and then say, okay, this patient is going to sepsis, in this what is the probability of him or going into this, or what is the probability of readmitting of this patient in 8 hours or 12 hours or 24 days. That's prediction. Okay, so perception is you're looking at a X-ray scan, you're looking at a radiology image. Okay, you're viewing that there are two tumors, like a human. There's a perception, right? And then, or you're listening to a patient, physician audio, and then you're identifying disease because you're perceiving the sound there. You're understanding the sound there. Same thing is text. Text seems very simple. One of the hardest is text, actually. That the last one that came is out from these models is actually text. So because text has different contexts. So understanding the text in what context they're talking about it, what is the relevance of it, that's what perception is. You're understanding the language, you're understanding the image, you're understanding the audio. That's what human perception. And in some sense, those are intelligence. That's why it's AI. But that's where. But we need to understand that's different. Yeah. Is that clear, Dr. Suresh?
Yes. So, Neil, any questions?
Yeah, a couple of times it was asked that how can limited data be transformed into more accurate data for AI decision making? What tools and prompting technique can be help? Because I think AI would need a lot of data. Is generative AI is a solution? Because if the input is limited, how it can be predicted?
It is very hard. I mean, but people do generate data, do generate synthetic data. See, one of the things, I'll just take a detour for 30 seconds, okay? One of the things that you hear a lot of hype about AI is in the consumer space. Please don't bring that into healthcare space or other space, because you can be wrong in the consumer space. A recommendation on Amazon can be wrong for me. A recommendation for something else can be wrong in that space. But when it comes to healthcare, when it comes to certain other domains, it has to be very strict. So you're a model trained on synthetic data. You have to be very careful. And it's a whole different science also. If you're generating synthetic data, if you can validate that data is closer to a normal data in terms of its distribution, in terms of all the things, right? Maybe. But it's a very loaded question. Yes, people use synthetic data. And how, whether can I use, there are two parts to the question. See, can I use synthetic data? Yes, you can use synthetic data as long as you understand what you're building, and then you understand let's say you're okay, let me step back. The synthetic data you're generating, if you're generating that using some sort of knowledge that you have, that there are different use cases, this kind of data comes like this, that may be okay. But the synthetic data you're asking GenAI and it's generating, you need to understand what it generated, how representative is that, how real it is, how close to real it is. A simple answer is that in some sense.
So just before we close, they just want to understand a couple of medical examples. So just to relate ourselves with the topic. So just take some random example. I'm just giving diabetes and heart attack, or hypertension and heart attack. How does the stats look at it? How does the AI look at it?
Yeah. So diabetes.
I'm just giving a very last 2-3 minutes. So let us assume that I have 10 diabetics. Few of them have hypertension, few of them have lipid profile, few of them have 2D echos done. They have history, genetics, everything available. How does the stats look at it? How does the AI look at it?
Okay. I'll actually even decide for that, but please help me, Dr. Suresh, if I'm saying something wrong on the medical terms. But on the diabetes side or anything, right? So you have a number. When somebody does a test, there's a number. And the number falls on pre-diabetic or diabetic or high, right? So that is a confidence interval. That is done because there's a statistical study that is done, and then somebody published that this is the range. This is the confidence interval that whatever this is the range that somebody falls in. And then that is why they're called pre-diabetic. That's why they're called diabetic and things like that. So that's what is, and it's used day in and day out. Like I said, statistics has been used over 100 years, I mean, many years in healthcare. So that's bread and butter. I mean, you probably are using it as I speak also, right? In some other patients as well. So that's on the statistics side. On the machine learning side, I'm answering AI in a, like I said, like my own thing, like on the machine learning side, and I'm going to answer in other things, right? So on the machine learning side, what you can do is, let's say I want to understand a patient's behavioral aspects and predict if this patient can become diabetic.
Okay.
That's machine learning.
Right.
Okay. And deep learning is if I do diapathy, right? If I look at the eye images and then I'm trying to predict, I'm trying to look at a pattern there and then say this pattern is diabetic, this pattern is not diabetic. So you're using high dimensional image and maybe an early warning comes in. The utility, I'm not talking the clinical utility. I'm just giving an example. Okay, retinal diapathy, right? So am I saying it right? In retina, so right. So that's where the deep learning comes in. So now, if you can obviously that's how the difference. I hope the difference is there. One is very clear. Statistical model, you're looking at the average, where this patient fits in that average is one thing you're looking at. The other one you're looking at, given this patient, remember the Hippocrates thing, that I want to understand the patient first, not the disease. Given this patient, can this patient become diabetic? Or how fast is it progressing, or whatever it is, right? And on the if you have high dimensional data like their eye images, and you can do retinopathy, like kind of a thing, then you can identify the patterns there and also use that for your prediction.
Got it. So if I understand, there is a lot of questions. What is the meaning of high dimension? I tell my understanding after this class, anything beyond the numbers is high dimension. If I just have to put it in simple thing, it could be a speech, it could be a vision. So that's what we call as a high dimension, right?
Right, because you cannot convert them into numbers. You cannot convert an image into a number and then run a statistical distribution there.
Right. So anything beyond number, you require AI, whether it is a machine learning, deep learning, or something. How to do that is what we are going to learn.
Even with numbers, there's a small catch there. Even with numbers, if the number of predictor variables are too high and complex, sometimes you use machine learning. You don't use statistics because there's too many to model the distribution. So right.
Numbers also inclusive in the AI, but statistics stop at numbers. Right? So
but the good thing about statistics is, not to say, the good thing about statistics is it gives you inference, it gives you causation. It's not just, and it gives you evidence.
Authentic. It's more authentic.
Give evidence, not prediction.
Got it. It's more authentic, it gives evidence. Thank you very much, Neil. Any other questions? We have just another 40-50 seconds left before we just close and then just thank everyone.
I think it's a meta question that somebody also asked. So how can AI tools be implemented in slow changing field of medical research? So I think it's a question of adoption, because the way we are trying to learn now is for becoming future ready when it will be part and parcel of the day-to-day medical system, right? So do you have any views on that?
So this is an opinionated answer, obviously. This is an opinionated answer. So what happens is the adoption can come because there is certain things that it automates, or certain things that it does that as a human we cannot identify early signs. We cannot identify certain things that is bringing a lot of value. That's when you adopt. Okay, first thing is right. And then the second thing is you're using for your productivity also sometimes, right? So you're using, you're quickly checking it out and then doing your product, and using your judgment to override it if it doesn't give right. So the adoption comes from both the innovations that are coming in through that, because it's seeing a lot more things, and that is what is inevitable in some sense, because there's so much, like I said, both big tech and healthcare are actually on it. So there's a lot of innovations that come in. So that's because of it. And second thing is at a personal level, I'm using it because it improves my productivity. I don't need to, I can see more patients, or I can have more free time. Either way, whatever it decides, right? So the adoption comes from others, and then there is organizational adoption as well, but on for efficiency. That's the third aspect.
So we are just on time. Thank you very much, Dr. Kishore. I know it is extremely complex. So in the beginning, even few of us will have some difficulty in catching up with the speed and with the new terminology. But at the end, if I just look at the chat box, people are slowly getting into the pace of understanding this language. It takes time because it's a new learning for most of us. Thanks, Neil, for summarizing the things and then just helping me in making doctors understand a part of what these things is.
Sure. If not anything else, Dr. Suresh, all I say is if you think that AI is biostatistics are different, they both are needed. AI is not one blob of monolithic thing, and doctors need to understand that in that way. If that's conveyed, I think that's a good start for the rest of the series.
That's helpful. There are a lot of new terminologies. I think we need to just go back, look at the video once again, understand more. If not, I'll just I just want to just answer a few of the questions which are posted in the box. We may share the PPTs presentations to those who attended the class after the entire season is over for you to go through. But if you want it before that, I think we need to internally discuss and then just get back about the feasibility of it. So that particular questions may not be posted again. We are looking into it. Over to NBMS. for conclusive remarks. Ashton,
Thank you.
please.
Thanks, everyone.
Thank you.
Thanks for attending.
Thank you all for joining this webinar for the wonderful session.